Greetings to all. It is a great pleasure to be here with you, participating in this amazing event. We are going to talk about the 2 decades of cardioneuroablation for reflex syncope. Where are we now and what can we expect in the future? I am really excited to share with you our findings on this topic since 1998. I want to thank the Polish Cardioneuroablation team for the honorable invitation and congratulate them for organizing this outstanding Cardioneuroablation Congress. You have played a fundamental role with dedication, competency, and reliability, making the cardioneuroablation prominent worldwide. I'm Dr. Pachón, professor of electrophysiology at the São Paulo University and the director of the São Paulo Heart Hospital Arrhythmia Service. The origin of cardioneuroablation lies in the finding of atrial fibrillation nests. Why atrial fibrillation may occur in normal people without fibrosis or tissue pathology? To address this question, in the 90s, we conducted a prospective controlled study based on spectral analysis of endocardial potentials in sinus rhythm. We found that the atrial myocardium is composed of 2 tissues, a very well-connected muscle, the compact myocardium, and another one with electrically disconnected cells, the fibrillar myocardium. Clusters of fibrillar myocardium form the so-called atrial fibrillation nest. We also found that atrial fibrillation is maintained by electrical resonance of the atrial fibrillation nests. We observed that the ablation of the atrial fibrillation nests had 2 consequences. The first one is that the atria become resistant to the atrial fibrillation reinduction. The second consequence of atrial fibrillation nest ablation was an intriguing and significant vagal denervation. We used it to ablate all atrial fibrillation nests identified by spectral mapping and conventional recording. In this example, heart rate variability, the SDNN of 163 milliseconds before ablation, dropped down and kept reduced to 78 milliseconds 2 years post-cardioneuroablation. It denotes significant vagal denervation that persisted over the long term. In this well-controlled study, published by Professor Enrique Pachón et al., using extracardiac vagal stimulation, we found that atrial ablation outside atrial fibrillation nest does not cause vagal denervation. On the contrary, ablation of atrial fibrillation nest causes the complete elimination of the vagal effect, resulting in total vagal denervation. These findings suggest that atrial fibrillation nests are the neuromyocardial interface across the entire atrial wall. Considering the possibility of mapping and ablating the neuromyocardial interface and the potential for catheter vagal denervation, we proposed the name cardioneuroablation, which combines the words heart, nervous system, and ablation into the acronym CNA. The goal was to achieve significant and long-lasting attenuation of the vagal drive, treating atrial fibrillation and functional bradyarrhythmias without pacemaker implantation. Here we have a simple schematic view of the cardiac autonomic nervous system consisting of pre- and post-ganglionic neurons. The parasympathetic system is millions of years older than the sympathetic one. Only the parasympathetic neural body is located in the atrial wall, and only this can be eliminated by endocardial radiofrequency energy. In normal condition, this neuron releases acetylcholine that acts on muscarinic receptors in the atrium, causing extreme cardioinhibition, transient cardiac arrest, and a huge atrial refractory dispersion. It is responsible for the cardioinhibition that causes syncope. The muscarinic effects are completely eliminated by atropine. Sympathetic and sensory neurons are away from the heart and protected from radio frequency. Therefore, they are preserved and their fibers recover in a few weeks. After cardioneuroablation, there is an important and persistent chronic reduction in both the parasympathetic and the sympathetic tone. During cardioneuroablation, longer radiofrequency applications are required in the presumed areas of the four main ganglionated plexi: the place 1 between the superior vena cava and the aorta, the place 2 near the insertion of the right pulmonary veins, the place 3 in the region of the coronary sinus ostium, and the place 4 near the insertion of the left pulmonary veins. To simplify the innervation mapping, in 2005, we developed a software in cooperation with St. Jude Medical to mark innervation on the electroanatomical model. This software is currently provided by Abbott as fractionation mapping. In this figure, the gray areas point to regions with a high probability of innervation, while the purple areas show myocardium with a low likelihood of innervation. A significant part of the innervation map overlaps with the main ganglionate plexuses. In these areas, ablation should be longer to obtain a transmural effect. Here we have a map reaching complete denervation and elimination of the vagal response. The most important denervation point is called P point, because it gives origin to the most of the innervation of the P cells and of the sinus node. It is located in the left interatrial septum between the insertion of the right pulmonary veins, roof of the left atrium, and fossa ovalis. The GP2 area is usually near, located at the insertion of the right superior pulmonary vein. The GP3 area is typically assessed at the insertion of the coronary sinus, as well as the region of the Marshall's vein in the roof of the coronary sinus. The GP4 area is close to the insertion of the left pulmonary veins, and finally, the GP1 area is assessed by the superior vena cava. In some cases, may be necessary ablation of the Waterstone groove and the other areas indicated by fractionation mapping until vagal effect elimination. In addition to the mapping system, it was necessary to create a way to directly measure the vagal denervation. For this purpose, we developed the extracardiac vagal stimulation to confirm the denervation during the cardioneuroablation. In this method, a catheter is advanced through the internal jugular vein into the jugular foramen, where we can easily obtain non-contact vagal stimulation. The typical response is a systole or high-grade AV block, and at the end of the procedure, these vagal responses must be eliminated as the best endpoint. Here there is a real example of the extracardiac vagal stimulation in a patient with neurocardiogenic syncope. In the upper tracing, we see that 5 seconds of vagal stimulation causes an immediate pause due to the action of the acetylcholine on the M2 muscarinic receptors of the sinus node. With the rapid metabolization of the acetylcholine by acetylcholinesterase, there is a fast recovery of the sinus rhythm. In the lower tracing, the extracardiac vagal stimulation was repeated after cardioneuroablation was ended. There is a complete absence of the vagal effect with no bradycardia, no pauses, and neither AV block, demonstrating that the cardioneuroablation was successful. The extracardiac vagal stimulation offers the best endpoint for cardioneuroablation. Sometimes may be difficult to get the jugular foramen to make the extracardiac vagal stimulation. In this case, it's possible to get the vagal stimulation along the jugular vein. Piotrowski and Coles have been showing that ultrasound-guided extracardiac vagal stimulation is feasible, and the full vagal response is achieved significantly more frequently than using fluoroscopy-guided extracardiac vagal stimulation. In this study, we compared the anatomical cardioneuroablation with the electrophysiological cardioneuroablation controlled with vagal stimulation to get the best denervation endpoint. We found that the cardioneuroablation controlled with vagal stimulation by eliminating the vagal effect has a 5-fold lower recurrence of syncope in 5 years. In addition, vagal stimulation is very important to mitigate the undesirable effect of the operator's learning curve. We performed the first cardioneuroablation in 1998, but the first publication was made only in 2005. In this trial, we found a remarkable effect in 5 cases of neurocardiogenic syncope, 7 functional atrioventricular blocks, 13 sinus node dysfunction, and 9 cases of paroxysmal atrial fibrillation, covering the main indications for cardioneuroablation. The first randomized controlled trial was published in 2022 by the Poland group of Roman et al., showing the effectiveness of cardioneuroablation in patients with cardioinhibitory neurocardiogenic syncope. The authors compared cardioneuroablation with clinical non-pharmacological treatment and found 8% of recurrence of syncope with cardioneuroablation versus 54% with clinical treatment in 2 years of follow-up. In addition, there was a very significant increase in quality of life. This study was very well conducted and demonstrates the great potential for the clinical application of the cardioneuroablation. The cardioneuroablation results have been improving significantly with the progress of the technique and with evolution of the learning curve. In the red plot, we can see the syncope-free survival of empirical cardioneuroablation without vagal stimulation control. The survival plot in blue shows the clinical follow-up after cardioneuroablation controlled with extracardiac vagal stimulation, ending the procedure with confirmation of denervation. In green, we see the result of the clinical treatment published in the trial by Roman et al. In purple, we see the results of the Roman trial, the first randomized trial of cardioneuroablation. Finally, in blue, there is the result of the Spain trial using a pacemaker. However, the comparison is hampered by the short follow-up. In our experience, cardioneuroablation controlled with vagal stimulation allows syncope-free survival in near 90% of cases in a long follow-up up to 60 months. The comparison between cardioneuroablation and pacemaker has shown favorable results. In this study by Rakesh et al. With 162 patients, it was verified that 97% of cases of cardioneuroablation and 89% of pacemaker cases were free of syncope in a follow-up of 1 year. Most importantly, no significant difference in adverse events were noted between groups. Obviously, 1 year is a short follow-up, but the result is highly promising. Cardioneuroablation is a promising method that will continue to evolve with improved operator training, use of cardioneuroablation guided by vagal stimulation, direct mapping of vagal innervation, identification of the ganglionated plexi using functional 3D imaging, results of large randomized controlled trials, long-term safety studies. And we believe that the immediate future of cardioneuroablation, that is already present in our opinion, is its application in atrial fibrillation ablation. Let's see something further. Despite having large spectral difference, electrical potentials of fibrillar and compact myocardium may be relatively similar in sinus rhythm. However, after atrial fibrillation induction, there is a great difference with fibrillar myocardium showing very high frequency, disorganized and irregular electrical activity, whereas the compact myocardium shows a lower frequency, regular and very organized electrical activity. The induction of the atrial fibrillation by the vagal effect is clear in many cases, like in these patients, for example, that presented a spontaneous atrial fibrillation just induced by vagal stimulation. Therefore, the vagal denervation by cardioneuroablation added to the pulmonary vein isolation is highly desired. We may see that after the elimination of the acetylcholine, the sinus rhythm is recovered. In the same patient, a new extracardiac vagal stimulation identical to the previous one show no more vagal effect and no more atrial fibrillation induction. In cases with paroxysmal or persistent atrial fibrillation, the cardioneuroablation abolished the atrial fibrillation induced by vagal stimulation. This study demonstrates the harmful effect of vagal innervation on atrial electrical stability. In the upper tracing, the atrial refractory period equal to 260 milliseconds was determined without induction of atrial fibrillation. However, in the middle tracing, during vagal stimulation, there is a huge reduction in the atrial refractory period from 260 milliseconds to 80 milliseconds with immediate atrial fibrillation induction with a single extra stimulus. However, in the lower tracing, after cardioneuroablation, there is recovery of the atrial refractory period to 250 milliseconds without induction of atrial fibrillation or other arrhythmia. This demonstrates that cardioneuroablation prevents both the atrial fibrillation induction and the atrial refractoriness reduction induced by vagal stimulation. The extracardiac vagal stimulation has showed that the vagus causes a huge reduction of the atrial refractory period. So, let us now analyze the intense tissue effect of the vagus causing dispersion of atrial refractoriness. Let's consider two similar myocardial cells, A and B, that have an atrial refractory period of 208 milliseconds. Let's now add the vagal effect. Due to the lack of the motor end plate, the A cell will have strong acetylcholine action, while the B cell will have no cholinergic effect. In this way, the action potential of cell A is reduced to 80 milliseconds, and that of the cell B is maintained, resulting in a huge refractoriness dispersion of 200 milliseconds. This phenomenon is one of the main causes of the atrial fibrillation bursts and can be corrected by cardioneuroablation. Let's see now the effect of neurotransmitters on the induction of atrial fibrillation. In this elegant study, Sharifov et al. Injected adrenaline into the sinus node artery, and the atrial fibrillation was induced. Apparently, adrenaline causes atrial fibrillation. However, if adrenaline is injected after atropine in function, eliminating the vagal effect, atrial fibrillation is no longer inducible. This demonstrates that adrenaline produced atrial fibrillation when there is a vagal effect, but if it is alone, it does not cause atrial fibrillation. On the other hand, when acetylcholine is injected into the sinus node artery, there is always an induction of atrial fibrillation, demonstrating that acetylcholine is highly arrhythmogenic. Pachón et al. Published an interesting study showing that the paroxysmal atrial fibrillation sprouts are triggered by the immediate increase of both the sympathetic and parasympathetic tone. Therefore, typically, the paroxysmal atrial fibrillation begins with an overlapping of the adrenergic and of the cholinergic tone. This may be also explained by the intracellular calcium transient that causes trigger activity in myocardial cells. This effect is equally induced by acetylcholine and by catecholamine. Considering that atrial fibrillation episodes are triggered by an increasing of sympathetic and parasympathetic tone, the cardioneuroablation has a dual benefit in atrial fibrillation ablation because it chronically reduces both. This study shows a significant reduction in both autonomic tones up to 2 years follow-up after cardioneuroablation. The effect of cardioneuroablation on atrial fibrillation ablation is shown in this study that compared the outcome of 55 patients who underwent PVI with 72 patients who underwent PVI plus cardioneuroablation. The group treated with cardioneuroablation had 5.4 times less recurrence of atrial fibrillation in a follow-up of 2 years, showing that endocardial denervation has a positive impact on the atrial fibrillation treatment. So, based on these findings, we have been observing positive effects of cardioneuroablation in the atrial fibrillation ablation setting. The first one, the cardioneuroablation abolishes the vagal atrial fibrillation reinduction by vagal stimulation. Second, the cardioneuroablation prevents the vagal shortening of the atrial refractory period. Third, the cardioneuroablation reduces the atrial refractory dispersion. Fourth, cardioneuroablation prevents the atrial fibrillation induction by extra stimulus during vagal stimulation. Fifth, cardioneuroablation chronically reduces the sympathetic and parasympathetic tone. Thank you so much for listening to my presentation.